Welcome to the Assisted Living Podcast. This is episode 3. Today I have a special guest. He's a dear friend of mine in the industry. Been knowing him for a long time. He's an incredible physician, but on top of that, he's a more incredible human being. I've been wanting to talk to him on the podcast for a while. We've had numerous conversations of eventually doing this. So here we are today, Dr. Peter Hanna. Welcome.
Thank you so much for having me. I really appreciate it. I've been trying to get on one of these podcasts with you for a long time.
I know we've been talking about it. Yeah, I really want to share the information with the masses out there because a lot of people are going through a lot of struggles with their parents when it comes to healthcare. They don't know where to even start. So, been doing this a long time, have a lot of knowledge in this, and I'm just going to bring in our whole entire network and educate the masses. So that's why we're here today. Give our audience a little bit about your background, how you started. You're a DPM, also a surgeon, but just give the audience a little bit about your background.
Absolutely. Well, first, thank you again for having me here. I can't say enough good things about Andy. I've known Andy for a long time. He's easily one of the best human beings that I know, but also one of the sharpest minds that I've ever seen. So I've been watching what you're doing with the podcast, bringing awareness to multiple different things, and it's beautiful. You're doing the Lord's work. You really are. Absolutely. In many ways.
It all starts with him.
Yeah, absolutely. Amen.
Yep.
Like you said, I am a foot and ankle surgeon. I've been in practice now for about 10 years. And, initially I was in the sciences. I was in healthcare, running the blood banking division back in New Jersey. And then it wasn't doing it for me. I knew I wanted to do more. I always wanted to do something with my hands. So I always wanted to do surgery. So I ended up coming down to Miami. I went to school here and I got my medical degree. Then I went and did residency training over at Jackson and did orthopedic trauma training. It kind of went and developed from there progressively. Things have been really good, thank God. But I'm really passionate about this topic here because, as you know, I have a number of different practices. I have a large multi-specialty group. When I initially started the practice, it was only a foot and ankle surgery discipline. And over time, I knew where the direction of healthcare was heading, and it was always going to be multi-specialty. Any way that you can compete or stay relevant in a space had to have been a multi-specialty approach. I started bringing on different, some of the best, most qualified specialists out there, like, some of my guys, Dr. Luis Hernandez, Dr. Yelin Ruiz, my brother, Paul Hanna, he's my vascular surgeon and general surgeon, Dr. Austin Price, he's our latest addition. My foot and ankle surgeons are all double board certified. Dr. Rastami, who's been with me, we actually did training together. Dr. Ginsberg, he's just an absolutely amazing human being. Guy has a great head on his shoulder, one of the hardest working people that I know. And we're bringing on some new folks now. Things have gone really well, but because of one main principle, that we understand what the issues with healthcare really are nowadays. And what you brought up earlier was the biggest topic, and one of the things that I'm very passionate about. Because I always see the same thing. Patients don't know what they're doing with their healthcare. Patients are referring to an agent or a family friend who says, hey, join this plan or join that other plan, or the agent comes and offers them a gift card or offers them lunch for them to join a plan, and they really don't realize what they're signing away, what they're giving up. So they ended up declining. Their care ends up being managed by someone who is likely not the most adequate at providing that care for some of these complex patients. And that's why we're seeing a huge trend with the biggest issues in healthcare being in the geriatric population, because we spend all this time not taking care of ourselves. And then later on in life is when we have to deal with the consequences of all these things. Right. And that's my practice deals with some of the sickest patients you will ever see.
So you're starting to see a lot of these multi-specialty practices pop up. Can you explain to the audience, potential patient or somebody that has an older parent, why do you want to take them to a multi-specialty type practice versus just your traditional, primary care physician office?
Absolutely. Well, most multi-specialty practices should have at least some relationship with a primary care physician. You're never going to replace a primary care physician in this space, in this ecosystem. Why it benefits the patient going to a good multi-specialty practice is that everybody's actually communicating. For example, hypothetically, your patient comes in and the patient is dealing with one component of a chronic condition. For example, let's say hypertension, let's say diabetes. You know that you identify some things that a specialist will find over a primary care doctor in that area. For example, a patient with diabetes, I am more likely to diagnose neuropathy with the patient initially before their primary care physician will. So by the time the primary care physician actually gets the patient to a specialist, and a lot of constraints in that process, like the insurance requirements, finding a specialist in network and getting them referred and getting authorization, and finally getting the information communicated, there's a lot lost in translation. On the other side, of the patients in a multi-specialty discipline or multi-specialty practice where everybody's just down the hall from each other, my teammates will just knock on the door and say, "Hey, I think this patient really needs a look at it. Can you come take a look?"
Yeah, it's so important because we always talk about continuum of care. Like, so when I get in front of physicians like yourself, I always talk about continuum of care and extension of your practice out in the 100%. Home setting. And when you go to a multi-specialty practice, that's what happens. A continuum of care happens, and you will get better care if you go to a multi-specialty type practice.
Absolutely, and that happens live. We've had situations where even young patients with rare, undiagnosed disease, we've had these patients save their lives, if not just their limbs. But we've had these patients end up, saving their lives because we caught something right there that otherwise would have probably taken a month before that patient gets in front of a vascular surgeon, like one of our patients, or gets in front of a general surgeon. If we hadn't caught that live, that patient would have likely ended up in a much bigger problem than they have.
So you started in assisted living when you first started. We were having a conversation before we started the pod. Talk a little bit about your experience in assisted living facilities, and what I want you to maybe give some light to is to somebody that's going through that process with their parent or grandparent, and what are some of the things that they should be asking the community, the administration, when it comes to the care of their family member?
Absolutely. Yeah, assisted living facilities are one of the most important parts of healthcare. So the level of care that you're going to get there needs to be dedicated and differentiated based on the patient's pathology. So not every patient is going to be the same. As you know well enough, there's patients that need special needs, memory care patients that need a different type of sitter. You also need a good team in the facility that is going to still maintain good access to healthcare. For example, you can't put your parent in a facility that rarely has access to specialists, or that rarely has access to good primary care physician who is treating these patients that are in ALF no different than the patients that walk in through their door. So when I started in the ALF setting, I was very young. I was very hungry as soon as I came out, and every patient that I could get my hands on, I was going. So I drove all over, everywhere from Florida City all the way up to Palm Beach, and I covered the majority of ALFs down here.
How many miles were you doing a year?
Oof, yeah, I think I was easily doing close to 30,000 miles.
Oh,
yeah, 30,000 miles in a year. I replaced that car over and over again for sure.
I bet.
But it taught me a lot. It really taught me a lot. It put me in connection with a lot of patients. You end up connecting with them on a different level. These patients are, like your parents, like your mom, like your dad. You got to think about it, at some point in time, we're all going to need that level of care. None of us are getting younger. We're getting older. And as we get older, things like our arteries are getting smaller. Our tolerance to insulin is not the same. Our blood glucose is worsening. All these things add up to some of the worst chronic conditions, that basically debilitate us. So these patients often, much like the pediatric patients, they can't really fend for themselves the way that our typical population of patients can. So while the care for those geriatric patients in the ALF setting is not necessarily for everybody, it really requires a special heart. It really requires a deeper, compassionate approach towards these patients, so that you can still give them the same quality of care that you do to these other patients rather. So what I say to families that are looking for ALFs or assisted livings, When you do, you really have to do your homework well. Make sure that the staff on there is giving you that family approach that makes you feel like this patient, once they're admitted in there, this patient is going to be treated like family. Like this patient is not just a number, or this patient is not just someone that your CNA or your staff that's on site is just going to do their 9 to 5 responsibilities with them and go home. You also have to be able to establish a good rapport with these folks. You have to make sure that there's good communication, because a lot of times the patients aren't the problem. A lot of times the families are the problem. You often have to spend a lot of time just catering to the family members rather than the attention that should be brought to the patient.
Absolutely. So falls are a big thing in assisted living facilities. We talked about this in one of the episodes. But what advice would you have for a family member that has a parent or a grandparent that is suffering, from falls, and what advice would you have for them?
So falls are a big acute problem, but I think there's a much bigger problem that happens at assisted living facilities that is not paid as much attention to, and that's usually pressure-related ulcerations, progressive debilitation of patients. Once we if the old law of physics. If you don't use it, you're gonna lose it.
Right.
An object that stays in motion is going to continue.
Sure.
But as we get older, we're going to get less active. Once we start getting bed bound, chair bound, that's not activity. Even moving the patient from their bed to the wheelchair can be at least one step towards maintaining them a little bit more active. But it's not going to be the sufficient movement and the sufficient activity level that we need to get the patient's blood flowing, to get the patient's joints moving, and that contributes to basically their downfall. One of the biggest things that we see quite often is things like foot infections, diabetic foot infections, and then ulcerations. The cubitus ulcerations, sacral ulcers are a huge problem. The cubitus ulcers of the heel are a big problem. And patients progressively, when they stay in that state, they contract. And from all the literature, when they're bad enough from neglect rather than anything else, when they're bad enough, there's really not much that we can do for them. When these patients come to us in the hospital after basically avoiding hospitalization for a long time, the textbook answer is an AKA. So you can't even offer these patients a below-the-knee amputation. Most of the time, you have to offer them an above-the-knee amputation because of how debilitated or contracted they are.
So let me ask you this question. So primary care physicians in assisted living communities maybe go out once a month, right? You have some that will go weekly or bi-weekly. That's far and few between.
Right.
Care has changed a lot, and they use a lot of ARMPs to go out and see these patients, and they'll go maybe once a month, twice a month. But what signs, like at what point do you involve a podiatrist, right? And what signs should you be looking? Is it at the point where once you see a wound, you get a podiatrist involved? Like at what point, what signs are you looking for as a family member? You're saying, okay, you know what, we need to get a podiatrist involved.
This is such an important question and a great topic that we need to educate a lot of our primary care teams on. I do a lot of education, as you know, so. You should really recognize the risk factors for these patients. So one of the biggest risk factors is a patient diabetic. Once a patient is diabetic and has an additional risk, this is a CMS criteria. So once a patient is a diabetic and has an additional risk, like for example neuropathy or peripheral vascular disease or severe contracture, that patient needs to see a podiatrist at least twice a year for general evaluations. If the patient is neuropathic, like we said, that patient needs to see the podiatrist for at-risk care every 63 days. So every 63 days, you should be bringing in your specialist, your podiatrist, your foot and ankle surgeon to evaluate the patient. More so, how do you screen these patients? So a lot of times, and this is a big problem in the ALF population. A lot of times, like you said, you're going to send a nurse practitioner, you're going to send a junior physician to assess the patient. Ask me how many times I've seen this myself. Ask me how many times either a junior physician, someone who's new to practice, or a nurse practitioner. Ask me how many times they remove the patient's socks. Ask me how many times they check their legs. No, they don't. They don't.
Yeah.
And it's usually until a family member complains or something along those lines that they say, "Hey, we need a podiatrist urgently. I get those calls all the time. Can you come in here tomorrow? Because somebody saw something that really should have been caught a long time ago. So the manifestations of some of these diseases, like severe peripheral vascular disease, as you know, we have a limb salvage practice with our vascular team. We have the only integrated limb salvage practice in all of South Florida, shy of Jacksonville. So the manifestations will often develop in the farthest part of your body. What's the farthest part of your body? It's your foot, right? Because that's the area that has the smallest vessels, it has the smallest nerves, and that's the area that is going to be impacted by things like diabetes, things like peripheral vascular disease, things like ongoing heart disease, hypercholesterolemia. Those arteries, those vessels will stop functioning as well as they do. They generally become occluded first, and we are the first people to see it. So one of the earliest signs that you can look for is absent trophic hair growth. So if the hair growth is not so good on a patient's leg, that's something that should tell you, hey, let me get a specialist to come see it. If you start seeing discoloration on the patient's leg, if you start seeing overgrowth of the patient's nails or poor growth of the patient's nails, both of those are signs that you really should be calling one of the foot and ankle specialists. Yep. And then ask me how many people know how to check a peripheral pedal pulse.
Not many.
Yeah. Even doctors that are practicing, ask them, hey, do you feel a dorsalis pedis pulse? Do you feel a posterior tibial pulse? It takes years and years and years of practice to really be able to palpate that well. So if you're not equipped with the right knowledge, the right practice, you're going to have a hard time recognizing risk factors that these patients have and being able to address them appropriately, like, again, calling a podiatrist or a vascular surgeon or an additional specialist that you may need to help that patient.
Yeah, so, you know, there's always a running joke, you're a Google Doc or you're a WebMD expert now, blah, blah, and I've seen that in our field. And no one's saying that you need to go memorize WebMD,
Nope.
But you need to be educated, right?
Absolutely.
And you need to do a little research and understand what your parent's going through. Grab a face sheet, grab a progress note. You're entitled to that. And review what's going on. Ask the doctor certain questions. Use ChatGPT on what questions to ask the physician, right? Absolutely. You're entitled for that. So you're not bothering anybody. If they're bothered, change the physician.
Absolutely. I do this all the time. Every day, patients and patients' families want to speak to the doctor. Sometimes the patient is not as alert. And the person that I have to answer to is not just the patient, but their family. And you got to treat these people with compassion. You have to understand that they're scared. You have to understand that their father or their mother or their grandmother, that's their hero. That's the person that helped raise them. That's the person that is everything to them. And they don't understand what's going on with them. So if you don't spend that extra time giving them the confidence that you're checking off every box, you're dotting every I, crossing every T, then you really may not be the best doctor for these patients.
Listen, one of the things that doctors hate the most, you mentioned the word liability and lawsuit, and they run for the hills. And when they see that you're a little bit educated on, on the subject, they kind of move a little bit differently.
Absolutely.
So
Absolutely.
that's just the reality of it. What are some of the myths when it comes to, treating, diabetes, wounds, foot and ankle?
So most folks think that a podiatrist is just the doctor that clips your nails, and that's far from the truth. We treat the patient from head to toe. If the patient has a neurological problem, oftentimes we're one of the first people to diagnose it. Let's say they have ataxic gait. Let's say they have signs of Parkinson's. Who's sending them the referral to that neurologist? We're catching that first. Peripheral vascular disease is a huge problem. And again, who is the first person to usually diagnose peripheral vascular disease in a patient? It's usually their podiatrist. Right. So beyond good clinical evaluation and management, I myself and the majority of the team that works with me, we are reconstructive surgeons. So we do all orthopedic care up to the level of the tibial tuberosity right under the knee in the state of Florida. This is especially helpful to our population of patients because the patients are going left and right. They don't know whether to go to a knee specialist. They don't know whether to go to the hip specialist. Some orthopedic doctors will work only on the hips and not work on the knees. Some are, just the shoulder. And when you get your population of patients who have diabetes, hypertension, peripheral vascular disease, but also have orthopedic problems, they often don't have a doctor that actually will treat all of that.
Right.
And that's where we come in. We are the absolute one-stop shop, in-house specialist for everything that happens in your lower leg, your foot, your ankle, your everything in your lower extremity.
Got it. So I have a bunch of questions here. I'm going to ask you a few of them. They're like 20 questions, but I'm going to ask a few questions here, and I'm going to read it right off the sheet here, and just so we can continue, educating our audience here. Why are seniors so vulnerable to foot ulcers?
So seniors are vulnerable to foot ulcers because, again, over time, as we age, our quality of tissue or quality of the skin starts to break down. We don't have a really good fat pad, and also our activity level becomes worse. So as we become less active, we have less vascular blood flow to these areas. And if you don't water your grass is not going to grow. Same thing with the tissue. If we don't get good enough oxygenated blood to the tissue is going to start breaking down. So seniors, especially someone who is in a bed-bound position, someone who is in a seated position, whether on a wheelchair or in the bed, the more pressure they put on these areas, the less they're moving, the more breakdown that they get. And they are very susceptible because their immune system does not work as well as a young patient, just by the nature of it, not even factoring in any disease like diabetes or other conditions that impact their immune system. So these patients are very, very likely and have a high risk of developing ulcerations, and those ulcerations very quickly and undetectably become infected, and then you end up dealing with amputation.
Great. What are the most common wounds and ulcers you see in assisted living residents?
Usually in the bony prominent areas. So you see them in the sacral areas. You see it around the heels. You see it sometimes around patients who have big bunions, and we always tell the patients, hey, fix the bunion while you're young. And they're always scared about this big myth that it's very painful. I don't want to deal with the pain. But as you get older and your toe starts turning sideways, that bony prominence becomes an area that is high risk for breakdown of the skin. So wherever the bone is prominent, that's the area you need to focus on. That's the area you need to offload and apply as much care to.
This is a great question. I love this question. How quickly can a small wound escalate into if it's untreated?
Overnight. Absolutely. Things like necrotizing fasciitis, all that stuff you see on the medical shows on TV, or necrotizing fasciitis where it becomes very, very dramatic. That can happen overnight just from the break of your primary protective barrier, your skin. Gas gangrene, very prominent with our diabetic population. So these risks are real. These are one of our top reasons why we end up amputating patients in our hospitals.
Yeah, so this is going to be my follow-up question. So what does a good prevention program look like at an assisted living facility?
Well, that's a great question. So, we have our limb salvage protocol. We put together a combined effort with our vascular surgeon, our primary care team, and even some infectious disease doctors, as well as our team of foot and ankle surgeons, right? So one, identify the risk factors. Primary risk factors including diabetes, uncontrolled diabetes, diabetic peripheral neuropathy, and things like hypercholesterolemia or and hypertension, the trifecta of any disease. So once we identify those patients with risk factors, those patients need to get screened very closely. So as I mentioned earlier, you should be screening that patient once every 6 months or once a year as a primary care physician. Once you identify that the patient has a potential pathology, that needs to be investigated further. So what's the best way? So if you do what's called the Semmes-Weinstein monofilament test on a patient's lower extremity, on a patient's foot, and if the patient has absent sensations at multiple points, that should alert you to get a specialist on board. And that patient should be followed up closely every 63 days, every 2 months by that specialist for their at-risk care. Additionally, and a little bit more concerning is the peripheral vascular disease. So if your primary care provider is not really evaluating appropriately whether your arteries are patent, that's going to be a big problem. That's going to be something that is often missed. It's not going to trigger the podiatrist to come in. It's also not going to trigger the ultrasound to be ordered, and it's also not going to trigger the involvement of a vascular surgeon. So One of the things that we always recommend for our care team, whether it's the nurse practitioner or your primary care physician, have a handheld Doppler on site. Handheld Doppler will cost you maybe $30-$40, but having a handheld Doppler on site can easily help you listen to the sound of audible waves going to the dorsalis pedis, going to the posterior tibial artery. And if it's patent, fantastic. But if you start recognizing monophasic waveforms, if you start seeing problems with good flow, get the specialist consulted right away. Don't wait. Right. These are the things that time is tissue.
Right. Absolutely. Absolutely. Last question I have here, and I love this question because, people don't, preventive medicine stops the bleeding financially, right? Mm-hmm. What are the financial and health consequences of ignoring a foot wounds?
Oh, I actually have some good stats on that. Right. I have to. So when we developed our limb salvage program, we had to look into these things, and we started presenting it to different networks. I was a big issues with managed care here in South Florida. So whenever you're bringing in a new program like this, you have to come with receipts, sure. Right? So there was a study performed in 2020, and the study went back and did a retrospective analysis of patients with the identified criteria of patients with amputations, and looking back at the risk factors, and also looking back at the financial costs on the healthcare systems in the U.S., primarily in South Florida. That's how deep we got into it. But I looked at the financial implications of limb loss on the system. So let's say preventative care, for example, if you prevent the development of ulcerations, prevent development of infection, you catch disease early, these things may cost the payer and essentially the taxpayer, sure. and the insurer and the patient themselves maybe hundreds to a few $1,000s per year on their medical care. But when you let that go and it's neglected, and then the patient's first time addressing these issues when they're admitted in the hospital with a disaster, that costs hundreds of thousands to millions of dollars. Mm-hmm. So in 2015, the average cost in that population of the study of patients, what it cost the payer and the healthcare systems was about $4.7 million. Okay. Per patient. Not yet. $4.7 million. It's not just a group of patients, it's per patient. 2019, they went back and looked at those studies, and it escalated. It cost them now $7.9 million in care per patient, right? It continued to increase yearly by 25%. One of the leading diseases that's becoming an epidemic in itself is diabetes mellitus. And that's one of the biggest problems that's contributing to these patients and their limb loss. So you're going to notice that over time, this is going to be an area where a lot of our healthcare dollars are going. And guess what? It's entirely preventable with good care, with good attention to bringing on a specialist, or with good preventative care from the beginning. You spend a fraction of the money on the proper care and prevention of these diseases compared to what happens with these patients when they're much older. Also, some of the other rates that are really significant to look at is the rate of amputation and what happens to a patient after they receive an amputation. So our primary focus here is limb salvage. We try to do everything possible to save a patient's limb because we know what's going to happen if that patient loses their limb. The study shows that on average, a patient who loses one limb, again, from bad disease, injuries, and chronic conditions like what we mentioned, the patient is more than 50% likely within the next 5 years to lose the other limb because of that same underlying disease. Again, all of that, very preventable.
I bet. What's the government doing to incentivize, prevention of this?
I really don't see a direct program from the government that they're really addressing or incentivizing prevention methods besides their MIPS programs, and MIPS is only really relevant to a population of patients that is primarily Medicare or open Medicare, but it doesn't really factor too well here in our Miami area. So I don't think that providers are very much incentivized to focus on that preventative care. The managed care model has some benefits, but unfortunately, because of the way that the managed care model is structured, I think that it is a huge detriment to these patients that require special, because the managed care model, especially when these practices or these MSOs or these clinics are going risk with some of these managed care plans, they do not want to send out to the specialist. They do not want referral, because that is essentially money that's coming out of their pocket. So this is the biggest population where you're going to see a lot of sick patients getting hospitalized, and that's where these plans lose more money, because they're borrowing from Peter to pay Paul. They're saving the money on the one end, and they end up paying it to the hospital when they get admitted.
So I'm gonna ask you this question. We've had a lot of conversations back and forth over the years, but the biggest fundamental problem with our healthcare system is, I feel that it's more reactive than proactive.
Absolutely.
Why?
It's that same concept. If we're managing the patient, and we're basically in the managed care model, for example, and if we're managing a patient, we're able to save on them with minimal cost to us as a clinic, not our clinic per se, but I'm referring to the managed care model. But if we're managing a patient and not really spending a lot out of pocket, at the end of the day, it's financially driven. And I'm going to say this with the risk of getting burned. So, but I'm going to say it because I'm very passionate about this topic.
Right.
You have to put the patient first. It cannot be profit over a patient. And one of the biggest factors that has impacted healthcare is this movement to get the doctor out of the way and put the CEO in their place.
Right.
So, and it's coming down from the insurance companies from the top. This is their biggest moneymaker. Their biggest moneymaker is the Medicare population. So once we started getting these private companies into the managed care game, into the Medicare management, that's when things started going downhill, because they want to retain more of that money, and they want to provide less care. So while some pictures painted as these programs have a lot of wellness, preventative care, they have a lot of good structures, that's not the standard. And if I, as a doctor, just like all physicians, have taken a good Hippocratic oath, and we have a good work ethic, and again, there's always exceptions, there's always bad apples here and there, but the physician took an oath to do no harm to that patient in all ways, shapes, or form. So I am more inclined, once I see something, whether it's going to cost me money or if it's going to create a bigger problem, I'm still more inclined to put that patient's health care first over what it may make me in profit or what it may cost me in profit. Ask me how many Hippocratic oath were taken by a insurance CEO or managed care CEO.
None, zero.
Exactly. So the day that we decided to say, and we the physicians are the problem, by the way, because the day that we decided to say, I don't know anything about business, I'm not the businessman, I just want to practice medicine, that really opened the door for the business guys to come in and say, you know what, we'll take care of it. And so eventually, they got involved in the care of the patients.
It's such a complicated issue, right? Yeah. Healthcare, just in generally in this country, and people ask me all the time. I don't have the answer, but I know that this system that we currently have is a product of the current system because how they allow certain things, right? So how do you fix that? How do you go? I don't know, because they've tried Obamacare. That didn't work. Now you have this system
was set up for
and it's complete overspending. Yeah. And then what happens is it's complete overreach by the federal government when it comes to auditing everything that we're doing when we're doing it right. They allow Joe Blow down the street to get a provider, and with no medical background, no history of in our space of having a home care agency. And this is why you run into these problems. Instead of focusing on those issues and really trying to correct, you hurt the person that's really trying to help. You start minimizing margins. You have a bunch of issues that are going on right now with labor cost, challenges with regulatory challenges, labor challenges. You have inflation. People have to live, so you got to pay them well.
Absolutely.
So like, what's the answer?
So just like everybody else, nobody has the right answer. But what we can do is we can systematically break down what the problems are. Right. And there's some problems that people aren't even paying attention to. So what we're seeing right now is a huge decline in medical school medical school admissions, because nobody wants to get into the healthcare space. I personally, I advise a lot of students. I'm an educator, I'm a residency director, and I deal with a lot of students on a day-to-day basis, and I advise them really think twice before you get into this kind of debt, and think twice before you end up committing the rest of your life, basically being stuck in the system. Because once you're in, you're too invested. You're not going to get out. Yeah. But there's a lot of things that we have to take into consideration. I think some of the problems start with legislature. So we have to go in and really kick down the doors, not just knock on them. We really have to kick down the doors and force a change. And that's only going to happen with unity. One of the biggest issues, and it's very prominent down here in South Florida, is it's a dog-eat-dog world. We live in a very super-saturated area. Everybody wants to live down here. Everybody wants to open up a practice down here. And one of the first things that happen is they think that it's a competition. So if you're a doctor and I'm a doctor, basically we can't be collaborative. We have to be against each other. That means only one person wins, and that's always the insurance companies. Right. So we need someone to reel those guys in. The insurance companies have really gone crazy. The insurance companies don't want to pay for the service, regardless whether or not the service was done. They're doing everything possible to deny our claims, and it's very illegal. We've gone as high up as the Office of Insurance Regulation, and all we get is promises. Yes, we're going to look into it, but nothing really happens. So we really have to get our representatives involved. We really have to make sure that there's good oversight of these insurance companies, because right now they own the lobbyists.
Of course, that's what it all comes down to.
Not only do they own the lobbyists, they also own the pharmacies. They also own the pharmacy benefits managers. So everything that happens is controlled from one single person up top. So if it affects their bottom line, we're all screwed. So we have to take away that unity, that connection that they have, that control that they have. We also need to go in and take a second look at who is really allowed to open up and operate and open a healthcare business. So if you're involved in a direct healthcare business, let's say a primary care clinic, there really should be a physician involved, and that should be the person that owns it. In other states, it's like that, and those models tend to do a lot better than what we have here, because oftentimes what we're seeing is anyone that comes in, sometimes from out of the country, or that has a donor or a sponsor with a bag of money, they will go in and they will buy a clinic, they will hire the physician, they will open up, they'll start marketing and recruiting. But the foundation of that practice is not the healthcare of the patient. The foundation of that practice by nature is profit. It's the bottom line. Yeah. And when you start incentivizing that situation, you're going to end up seeing more patients doing worse.
And I want to make this clear, like in no way or shape or form are we promoting socialized medicine.
Of course.
I think medicine has to be privatized, and I tell people this all the time, because if you don't have competition, you don't have innovation, then you don't get a better
You definitely need the open
system.
market.
Yeah, you need an open market, but there needs to be guardrails.
Absolutely.
Right within the market and with these insurance companies, and you just can't be denying everyone. So there has to be a way, and I've always asked myself this question: why don't they put a commission of the most experienced, the best minds in the healthcare space to try to figure this out, where everyone wins, right? You're in business to make a profit, right? But the patient has to come first. And Absolutely. I think it's twisted. It's the other way around, where it's profits first, then the patient, and something needs to happen.
Well, I think it comes full circle from what you said earlier. This really stems from education. What's the thing that you encounter the most when you're dealing with the patients' families and their kids that really don't know where to put this patient? Yeah. It's lack of education.
Absolutely.
Patients don't know the difference between a Medicare plan versus a Medicare Advantage plan. As a matter of fact, they termed it Medicare Advantage instead of Part C, sort of to confuse the patients, because they think that they have an advantage over your traditional Medicare, right? Sure. So they don't know what benefits they're getting and what they're not getting. What all that they can tell you is, yes, we get transportation. Okay, fantastic. So we get transportation, we get a monthly gift card, we get access to an adult daycare. So I'm happy that my grandpa or my grandma is sitting there with other patients that are their age, but we're feeding them, cafecitos and pastelitos and making them sicker. And all that we're doing is basically just kind of babysitting them, and they kind of get a little bit of their medical care on the side. One person wins at the end of the day. Absolutely. And it's not the patient.
Yeah, and I always tell people this, they want to keep you uninformed, and they want to keep you uneducated. Absolutely. Right? Because if you're uneducated, uninformed, then they can continue doing what they're doing. And this comes in any space. If you look at the
Absolutely.
financial side in Wall Street, they want you to be dumb in the subject.
Mhm.
But we live in a world today where the information is on our hand every single day, which is our phone. And ChatGPT, Google, all these things, the information is there. You just got to put yourself to want to learn the information. I tell people that all the time. And that's where true change is going to come in this space, is when people really start educating. That's such a great point.
Absolutely. Yeah. They have to educate themselves on these insurances. It's a topic that almost nobody, even most doctors, don't understand how it works.
Right.
So they have to educate themselves on how these insurances work, on what benefits a patient has, whether the patient has Medicare or the patient has Medicaid, or the patient doesn't have Medicaid, which is our biggest population of problems, and they can't afford to, they're in that little gap where they make too much to qualify for Medicaid, but they don't make enough to afford a secondary insurance.
Right.
So those are the patients that end up being vulnerable to some of these Medicare Advantage plans. And they go in because they basically have no other option.
Sure.
So they really need to educate themselves on this. And if we have more people in the community who understand the risks behind going with these plans, and who may be able to speak up against it and select something else. For example, in New Jersey, my parents grew up and stayed in New York and New Jersey, and they, despite me warning them not to for a long time, I told them not to get a Medicare Advantage plan. But we ended up with a happy medium. While they ended up with a Medicare Advantage plan, it was not a plan that is completely at risk, and it's not an HMO plan. So even if you're inclined to get a Medicare Advantage plan, do not go for an HMO plan that has you completely at risk. That means that you're only tied to that one provider, that one clinic, and that's your gateway to any other access to healthcare. So my parents are not in that situation. They have a PPO plan that's also part of the managed care. And it covers everything for them, and they're not responsible to pay that extra 20%. Whereas a Medicare patient who does not qualify for a secondary may be responsible for 20% of their care.
Right.
So it's a great topic. I love speaking about it. I can't tell you the amount of patients and their families that I sit and educate about on a daily basis in my practice. But I think it's something that more providers need to learn, and more providers need to have a good connection with their patients about, and talk to them, because they listen to the providers. If they're more likely to give them better advice that's better for their healthcare than your insurance agent.
Sure. And I think when you start getting into your 50s, mid 50s, and you're hitting 60, you're about to be 65, and you're going to get Medicare, you need to start thinking about secondary insurance.
Absolutely.
Right? What is going to be your plan? Because that is the biggest factor of what your care is going to look like for the rest of your life. Yeah. And people don't realize that, right? So, do you save up, or do you make sure you have something in place that you can afford an AARP, where you're not beholden to an HMO?
Absolutely.
Right?
Absolutely. And I think more and more people need to understand that there's a problem with a lot of our population here in kind of relying on the assistance that's associated with Medicaid, or the assistance that they might receive. And it's the last thought on their mind. They'd rather go spend the money on the new phone, or they'd rather go spend the money on a new purse, than really think about their health. And unfortunately, that comes to bite all of us in the butt later on. So bringing back things like major medical, making that more of a common thing, bringing back things like supplementary insurance, and making that more mandatory for those patients that can't afford it, I think it'll help everybody overall, because the cost of insurance, the cost of health insurance down here is astronomical. It's absolutely crazy. Yeah. But the more people that actually start buying these insurance plans and sort of hedge the bet, it will take our costs down. It will cost us less in healthcare, and it'll give you better access to medicine.
Yeah, you don't see these long-term care plans as relevant anymore, where you can pay for a long-term care plan and it'll cover your assisted living, your private duty, cover all these things later on. There's still some out there. They're rare. Yeah, they're out there, but you guys need to look into it. And this message is for anybody that has kids. And my brother and I were speaking about this other day. Yeah. Like, the number one goal I have two goals with my kids, is to turn them into amazing human beings, and that they can fend for themselves in the world. But the second to that is for us not to be a burden on them. And my brother and I were having that conversation, that when we get older, we do not want to be burdened on our kids, because it's a burden to carry healthcare costs, to be on top of you, right? Because you weren't set up correctly. And it really sets back families. It causes divorces. There's a lot of underlying factors that people don't see when it comes to healthcare, in this country, and if you're not prepared for it, it becomes a tsunami, and it could break the family dynamic that you have.
Absolutely. You know, healthcare is often an afterthought for most patients. So it's something that needs to change. And like I said earlier, it needs to change with legislature. You know, you can't drive a car in South Florida without having insurance, right? Without having at least a minimum amount of insurance. You should not be able to live in the state. You should not be able to, take part of the benefits of the state without having good health insurance, because it's an impact on the system as a 100%. Whole. If for everyone that wants to talk about socialized medicine, start with that and see how that works. You know, but socialized medicine, we know the model doesn't work.
It doesn't work. Yeah. It does not work, and that's not what we're saying here. Yeah. And insurance companies are needed.
Absolutely.
I'm not saying that they're not needed, or the HMO companies are not needed. The cost has to be managed some way, but the system has to be better, and the system is incentivizing big business before taking care of the patient. And that's a problem. Absolutely. Man, listen, I can talk to you all day.
Me too, man. Me too.
But let our audience know where to find you. Where's your practice at? Just drop it on them. And I'm not overstating this. He's one of the best human beings you'll ever meet. No, and really if he takes care of you, trust me, you're going to be in the best hands possible.
No, likewise. I've learned so much from working with you, from working with Zeus, and it's been just absolutely incredible. You guys are tremendous examples to the community, to all of us here, and I'm so thankful to be a part of this. So for anyone that needs even advice, even just general. Hey, what insurance do I put my parents with, or what's the best doctor to go to? These are questions that a lot of people are often confused about. I'm always available. I'll leave some of my contact information for anyone that wants to find us online. I have 2 very large practices, multi-specialty medical centers. One in the heart of Miami in downtown Dadeland. We, the big glass building over in the BMI building. We have beautiful the entire floor there. Thank you. And they can reach out to us there on our website is sflmedicalgroup.com.
So we'll put the website, the link in the bio.
Or you can obviously reach us to our phone number. We'll leave that there as well. But also great news. You know, we've been in the Homestead area for a long time now, and we know that that's an area of critical need. It's been one of our biggest hubs, one of our biggest populations. So after seeing how many patients really are in need of good care, good surgical care, good vascular care, good preventative care, good primary care there, we knew that there's a niche there that needs to be filled. So we just bought a large, almost 2-acre property.
Congratulations.
And we're working on it. It was a church, it was a synagogue. So I know it's going to be very blessed. Yeah.
The little bit of hair you had left, I know you were pulling it.
Oh, yeah, that's all gone. Yeah, that's all gone. Yeah. But yeah, that thing is going to be the next big thing to happen to Homestead, to come to the community. And we're going to bring in all our services from podiatry, foot and ankle surgery, internal medicine, primary care, wellness, regenerative medicine, preventative care. And the biggest program that we have in South Florida is our unique integrated limb salvage program, where it has vascular surgery, general surgery, and foot and ankle surgery. We have our own in-house surgical suites. We're going to build 3 operating rooms over there, as well as, for everybody that wants a little of the Botox or the fillers, we have one of the best medical spas in Miami, Lumea Med Spa.
Love it. Yeah. The city of Homestead is a growing one. I sit on the board at Homestead. I'm chair counsel at Homestead Hospital, and you're seeing an explosion,
absolutely,
in the population down there, and it's well needed. I just want to rephrase something. I'm going to put the link to his practice on the description of this episode, so you can go on there, click it. You can find it. But brother, thank you so much.
Thank you so much for having me. It's been great. I love these topics. And hopefully I'll come back sometime soon.
So make sure to subscribe, like, comment. We're really trying to grow our channel.
Absolutely.
And it doesn't cost anything to subscribe. It's free. And please support us, because this information needs to get out there. We need to get it to the masses, because people just don't know. So again, thank you. And, continue to tune in.
Only you guys can make the difference in healthcare.
Amen. Amen.